we can see the rest of you.
Yeah, good. As long as that's okay. But anyway, thank you, and of course, thank to Dr. Waxman to
Tell
give
them to put this camera.
this chance for this live relay, and I'll show you how similarity is the case from last year versus this year. But I know many of our faculty and fellows who returned got a great 2-day experience, and I'm sure today was the same one. And hopefully this is kind of a grand finale, right? I mean, today is the last day, and
Tomorrow,
we probably
we'll
will be
have tomorrow.
tomorrow. Okay, so we'll probably will be the last of that, or today case wise, this case. And thanks to all the panelists. I know some of the name we heard, and some we have made it. Myself, Dr. Kini. Then we have 2 fellows, Tushar Mishra and Pratish George. We are total 8 regular intervention fellow, 1 hybrid fellow, which is research and intervention, and then we have 3 endovascular and 3 structural fellows. So clearly, very busy lab, and we want a lot of education. So hopefully, that's what we'll do today about this case. And if okay, John and Divir, we start showing the case. Okay. Now this, good. So this is the case, March 10th, 2025. It was supposed to be 2 o'clock, but we pushed it. Protected high-risk PCI in an elderly patient, 87 years of age, with extensive 3-vessel and left main CAD, low EF, high syntax score, and STS risk score of more than 5. You say, well, what is the similarity on this case versus we did last year? And look at the ready here, March 11th, 2024, although 2 hours early, that patient, this is not the same patient, but 1 year younger, exactly the same scenario. So what a great case we could find for this educational teaching which we had last year. Anyway, to come back to the point, this is the patient with 87, again presented with heart failure, reduced ejection fraction, positive troponin, high BNP, never had angiogram till age of 87. And one of the things which started was his ejection fraction went low. What he was restricted, or I was cautioned that don't get an angiogram because the creatinine kept going up. It's like about 2.8. The risk factors were very controlled, as you see on the left side, and basically was not on much medical therapy point of view. Apparently part of that, his creatinine, they were concerned. And cath was done, which is going to show, along with moderate pulmonary hypertension and 3-vessel disease, EF of 27, syntax score 42, STS risk score 5.1. With this age, this EF, heart team discussion, this is, as I said, almost 6 weeks ago now, 6-7 weeks ago, they declined. After the more surgical point of view, that if we can take care of the percutaneously, and we thought that this was the right case for our discussion today. If Anu can show, Anu, okay, go to the fluoro, please.
Yeah. So this is where we have the LV gram with the EDP about 20. EF already by echo we have said that it is low.
Now, what about the right heart? You did a right heart also baseline. How was it? PA pressure. Okay. Yeah, so PA pressure definitely has decreased. It was moderate hypertension before, now it's a mild. And this is the angiogram. Okay.
So this is the left-sided. If you can see, distal left main significantly deceased. Ostial LAD is involved. And then there is this large, I would say OM2 or LPL, you can call. It's about moderate 60-70 disease. So this was a dry cine, good old way of understanding is this calcium or no. It's not heavy tram-track calcium, but definitely moderate calcium. You see specules there in the LAD territory. So this is where we are. The creatinine today is 2.8, so limited picture we had. So large diag, significant disease, though the bifurcation of the LAD diagonal is not involved, but LAD further diagonal further bifurcates and significant disease. This is the right coronary artery, again no calcium, but this is the lesion.
Subtotal, yeah. Did we fix it or no? Yeah. So that's where we are now, yeah.
Yes.
The question is, what sort of renal protective things are we doing since you have an elderly person with a pretty significant creatinine?
Yeah. So I mean, the key is we brought this patient early morning, and because of the EDP, I mean, because of LV dysfunction, we started him on 50 cc an hour hydration, and this patient to the 8th hour of hydration now. And then of course there are some data to support Impella might help, but although danger shock didn't show it, but that part is still ongoing. So if we can go back to the presentation so I can complete it and then we show where we are, just to show the presentation point of view. Go back to slide, please. So this basically the plan now is the Impella supported high risk PCI. I'm sure can have a discussion, but this is the I would say ideal case for this type to use some kind of a support device, particularly if there is no LV thrombus. Many of these cases, the problem with the LV thrombus is you cannot use Impella, then those do with the balloon pump. So this is plan will be how many vessels we can take care, and of course use the rota cut, maybe rota IVL, and so this is basically we know from the our guideline that you calculate all of them in terms of the heart team discussion had STS risk score, syntax score, frailty, not frail. 42 syntax score is STS of 5.1, and by our guidelines point of view, still the old OC, it's M, but it's actually after heart team discussion, I say it's appropriate in this particular case. And of the three devices, tandem heart very rarely used now is all Impella or balloon pump, and this is the we show all the time. This is the center. The red one is the one which at present being randomized into the Protect 4 trial. And as you know, Protect 4 trial is just coming to conclusion of the 1250 cases headed by Greg, and 1000 plus cases have been done at Sinai. We are number one with the 75 patients. My second competition is in Germany. They are 72. And this trial hopefully will answer this question. And the last one is that this is the type of patient ideally should go for surgery. But if surgery is not possible for various reasons, after heart team, guideline directed medical therapy and with PCI, that's where we are. So Anu, tell us what you did so far.
No, let's go back to the question is, do we take care of every vessel that we see here, or do we just focus on left main LAD?
With that subtotal proximal RCA, yeah.
Can I
Got
ask a
some people on
question?
the panel want
Yeah.
to chime in.
Yes.
I see the flow in the RCA is kind of slow, right?
Yeah.
I wouldn't call it TIMI 3 flow, so it looks like probably TIMI 2. So that's kind of one thing that definitely would take care of on this admission. And particularly, once you inject contrast, those become unstable. This looks very calcified, so probably not, but definitely would take care of this lesion on this.
Beautiful. Yep.
I would agree with that too, and it looks like you were going with a rotocut strategy. I'm wondering, was that based on intravascular IVUS or just on the initial angiogram?
That was based on initial angiogram. Yes, the only issue with this patient is elderly and creatinine is high. So if you are planning to do all three vessels, so we may have to be cautious.
Yeah.
But
point is you cannot get away from the right. No, right was disease about 90, but now became 99. This is about 6 weeks later. And it was angiogram was done somewhere else, but 99%, this one we had to take care of it first.
We agree, that's sort of the culprit right now, and
Yeah.
then you sort of move as long, as fast as you can, and get done as much as you can safely. Do
Beautiful.
you have a cutoff in terms of the calculated amount of contrast a patient can handle?
now the eGFR is 28, creatinine clearance about 20. So I would say based on what the calculation, we should not probably go beyond 150 cc. Yeah,
Anything
probably that.
To
yeah.
me, keep in double digits. The double digit system in many of things works very well. In this case, less than 100. Okay.
So of course, so we just did workhorse wiring with a run through, was not that easy. Just the balloon, regular balloon expanded, then we used a cutter. After that we did the imaging, and then we placed the stent. So we are going to show you the imaging before, actually after the cutting balloon, but before the stenting. Without imaging, I planned for 4028. Now Kiski, you can quickly confirm.
Can you show the IVUS on the screen?
We're just wondering about the position of the impella, maybe the angle, but
Yeah,
it almost
so
looks like
our
it's
start
deep in
work.
the LV.
Yeah, no, it's, I think the angle.
At the angle.
We were
This is the
caudal to
proximal
see the
RCA,
ostium.
post-balloon dilatation. We use the Boston Scientific high-definition IVUS, Avigo Plus. So we use the 4 millimeter per second PUVOC. Actually, it's more than expected, a lot of calcium here. And this is post-balloon. So you see some like calcium modification at 11 o'clock. But most surprised one is at the ostial RCA. There's a elaptive calcified nodule, like 6 to 7 o'clock. Yeah. But we see a lot of calcium fracture, like here, like a 12 o'clock, and a plaque modification between the calcified plaque and the fibrous plaques. So we think it's a good plaque modification. And based on the reference area, this is a distal, like okay landing zone, not perfectly normal, but lumen is 3.7, and a size up 4 low, and the lesion length is 27 to the ostial lesion. So as Dr. Kinney mentioned, we put a 4 low 28 stent based on this IVUS.
Show the post quickly.
Post-IVUS.
Yeah.
So this is the post-IVUS after 4 low 28 stent. This is kind of mid RCA. Lumen is open. Now come to the edge of the stent. Yeah, good transition. Yeah, like circular shape. Well expanded area. And then nail the ostium. Just one point is at the level of the calcium nodule, it's elliptical shape. But area is like 9.3. It's optimal. So we stop there.
Good. Show the angio, and then let's go
Nice
to the.
diameter. It's
Yeah, very good diameter.
nice
Yes.
diameter despite the elliptical nature of
Yeah.
it, so I think
Yes.
we're good with that. And you've nailed the ostium, looks like, just perfectly.
Yes.
Did you flare the back end of your stent, or you just left it there?
Yeah. That's it. This is here.
Did you flare the back end of your
Flare?
stent that hangs out into the aorta? Just curious.
No, we did not flare. No. If you have to flare, you have to go back with the ostial flash, but we did not. That is the right way, I think, is like a millimeter sticking out, and it has to be. So we are able to re-engage it, and we could have avoided this. Once you're done IVUS, you've seen a good distal edge is okay and proximal is okay. You don't need to take another picture, but I think to just make sure that your there's no wire perf or your distal area is okay, you need another angio just to confirm things were okay once you finish the PCI. Now we are going on to the left side. This is where we are with the guide. Wired, can you show the IVUS there?
Sure.
The question is the same, that can we do the same strategy, balloon stent, right? I mean, I didn't do a guide shot for the same reason, avoiding dye. Let's go back to your, cranial picture.
Yeah. Actually, we didn't cross the IVUS, that mid part. So the start of the PUVOC is like 180 to 270 calcium, a little bit protruding inside. So might be with the calcium nodule. But like it's a spotty calcium. Like a tightest part is all like a dark attenuated plaque. It's a lipid plaque. And come back to the left main. Left main also like 180 degree of calcium. And the proximal left main is like a lumen like a 4.5. So this is a mid to, proximal to the left main PUVOC. We didn't cross this.
This is the proximal LED,
Proximity is where the
LED
calcium
and the
is,
left main.
because that
And what size guide do you
remember
have in?
the
Seven
it's a 7 French at the proximal to mid area, the IVUS would not cross.
No.
Correct?
No.
Okay, yeah, right there, right? Go back to where it did not cross.
Sure.
1 second.
This is a start of the PUVOC. Like 180 to 270 calcium.
Yeah.
But we are not sure more distally.
Yeah. Good. Okay.
What's the plan for the non-crossable spot?
So this is, we are ready with the rota. We put a rota wire, and since it's a short lesion there, rest is the left main, and so we thought 1.7,
Yeah.
and then we, if need to be, of course we do a cutting balloon and so. So actually I can tell you, I was happy that just the cutting balloon and high pressure balloon worked, because there was truly not a very severe calcium by our criteria.
At 175 because
Yeah.
it's not severely tight and it's
Yeah.
discreet.
Right. Good.
Not worried
Slow
about
down,
too
slow
much
down. No
about
talk,
distal
no talk.
embolization that would worsen the LV dysfunction.
Well, I mean, let's hope Impala does some work too. But yeah.
Any comments from the rest of the panel here? Anybody have any
Good.
different opinions as to the approach?
Maybe with the selection of rotational versus orbital atherectomy, if you can guide us of your decision.
I have a comment about MCS because, I come from Finland, and I would say that
we wouldn't implant MCS device in an 87-year-old patient. So we would stage procedure. First open the artery and a few weeks maybe with the
Agreed that if you weren't without MCS, you would, for the safety of the patients, have to stage it. Usually when you've got it in there, of course, you strike when the iron's hot and you do whatever you can do safely.
I'm sure same thing could happen in America soon with the Department of Dodge extra spending. So that is true. At some age group, you have to be, here is like we are doing a tower in 105-year-old. Because if you don't do it, somebody else will do it. Because that's the culture. Until this something came out nationally and from the guidelines point of view, it's very tough to defy of somebody the care. Yeah.
Any other compliments?
I'm just wondering, how are you planning to approach the bifurcation and the diagonal, which appears quite significant as well?
I would add to that, do you think that there's enough disease of the ostium of the diagonal to be concerned, or just leave it alone?
Now let's take the opinion from the people and then we'll tell you what we are thinking.
Yeah. Diagonal ostium, I don't think it is involved. So if we have to take care of the diagonal, then you got to take care of the disease way further down. And there's some calcium at that level also. So knowing that this patient is elderly, do we just focus on LAD, left main, and the circumostium and leave everything alone? That's what I would be inclined to.
Get the balloon.
The one thing we might do in our lab, and others, of course, would follow, is that sometimes it's nice to do an IFR with pullback. And you can see exactly where the drop-off is and use that to make your decision as to what's significant and what's not.
Yeah, I'm going to agree with your strategy too, right? If this were a 67-year-old, you might want to go after that diagonal, but we have an 87-year-old, you've already fixed it right, you're going to fix an LAD and a left main now. I mean, you're going to make this guy a lot better than he was to start.
And hope is EF will improve also. I know we didn't do any viability testing, but the patient never, except the first episode, he has this troponin positive of one high sensitivity, I think 172. He never had any clinical MI before. So could this be all hibernating myocardium and will improve? That's the one thing which we expect in this particular case, knowing that he lived age of 87 with such a significant CAD without having even a cat.
We have a 3O balloon, right?
Yeah.
Or 2.5? 3O is too big. 3.5 is too big.
Yeah, 3O20.
20.
So how was the burr going through, guys? Is any
Was-
resistance? Or?
Yeah.
Yes, I think after the diag, there was a
Same.
lot of resistance at the level of that small first septal.
Yeah. Where the trouble was with the IVUS, same place, actually proximal was no problem. I mean, distal left main was no problem. That area about 130, that's where the IVUS did not go. That took about 3 20-second runs, always maintaining the blood pressure of more than 100, which is, although in this case has Impella, a little different philosophy, but went through quite a bit. EKG, we are showing it there, yes. And was no issues at all.
You know
So
what?
right there by that septal perforator, you're
Yeah,
saying. was-
Yes.
that's right.
was-
That's
Yes,
right.
yes.
Yeah. So this is now we are putting a 3O20 high pressure. Yeah.
This is often misleading sometimes if you don't see a real 90% lesion there and you say, why did it get stuck?
Yeah.
And you find out that the plaque is so eccentric there that the bias is to the outer curvature, it's getting stuck on it. And the rotoblader kind of basically took the top off that.
Yeah. That is absolutely correct. Go.
Now the question is that circumflex, right? Do we even wire and image, or you think we can just stent across?
So I think let's take care of the mid LAD
Good.
first,
Copy.
and then we'll come back to the ostial left main. I mean distal left main and ostial circ as a part 2.
No, one stent can cover everything.
No, we don't want to cover one. You want one?
Yeah.
I
If
see.
we think
Okay.
that you want to take care of the ostial circ, let's do it now.
Okay. So go a little further with this balloon at 2 o'clock. A little further.
Okay.
Little more. Little more. I would
So
go a
let's-
few more. Little
Okay.
more. Yeah, good. Good.
We're gonna IVUS this after this.
Yes, we will do that. IVUS is ready.
And you can kind of get a side view maybe of the circumflex at the same
Ostium,
time. And see
yeah.
how
We can-
ominous it looks? Or
Yeah, let me go back and show
No, we'll do it new. We'll
No,
do it now.
No, I
Take
will
the
show you the
rotawire.
picture.
Because
of
now
the-
Looks
what?
like your balloons are expanding really, your balloons are expanding really well
Yeah.
after that rotational atherectomy,
Yeah.
so that looks great.
I think if the ostium looks okay, but we can definitely wire and image it.
Okay. No, but text the rotawire out. We don't need the rotawire.
This is a great example for the audience here that, you've got somebody who's got 5 or 6 different lesions, but given the considerations in terms of contrast, the age, the longevity of the patient, you want less is more, and
No.
you really want to prioritize what's the most important thing to get done. And here it's the right, now it's the LAD, and we'll work our way back. I agree with the diagonal, just take a pass on that if possible. And if for some reason the circle looked okay too, we'd take a pass on that.
Yeah.
How nice it would be to shorten it to just treating the distal left main and LAD.
I want to field the wire.
I agree.
Yeah, right, okay. So we are going with the IVUS to the LAD.
Yep.
And left main again.
Again, just to throw a plug in for IFR, sometimes we're surprised.
Mm.
We have disease that looks like, I got a 70% lesion of that osteal
Good.
circumflex.
Okay, good.
But when I
Nice.
wire it,
Let's start the
they have an IFR.
IVUS. Show the IVUS.
So sometimes it makes work for you, and
Okay.
sometimes it goes the
Still
other
some
way.
plaque. Okay, I start
Yeah.
plaque. Pull back.
Yeah, and once you get a.
Can we put the hemodynamics by the side?
Myocardial
That's
bridge here. Some dissection. Yeah, there's a lot of calcium.
But I
why
see
it's
it's a
getting close.
nice plaque modification.
Yes. Yeah, I will stop it.
So distal left main.
So here is a calcified
Okay, let's-
myocardial bridge.
Yes, okay.
And, but around here is some hematoma.
Wow.
So we should cover here. So after
Flush it
so maybe
Again.
distal edge is on the kind of myocardial bridge. And this was
go
not
down.
before we didn't
Go
close.
down.
But a lot like a 270 calcium, but I see a lot of calcium fractures after loader in the balloon. I think it's a nice
So
modification.
would you,
Okay, go osteal diag. You see the osteal diag?
Sure, 1 second. So this is the circ from
Oh, that's circ. No, further down.
yeah, 10 o'clock. So diag should come same direction. So I think this is our first diag here, very close to the osteo.
So looks like osteal diagonal is okay. Now you tell us osteal circ.
Looks
circ.
okay by the side view, but I think let's
Sure. So
wire
this
it
is
and
osteo circ from
take care.
10 o'clock.
Yeah, flush.
Yeah.
We can do osteal. IVUS.
Looks open by
good.
this pullback.
Circ. Go caudal.
Because
We'll
if-
do a
Those are
quick
nice
imaging
views
of the circ.
Yeah.
Yes, a lot of fractures. And
some nice views of the fractures there, so it
Yeah.
doesn't look like you need to do any ballooning or IVL on top of that.
All right. So it will be rota
Yes,
approach, no
agree.
rota cut.
Agree with the plan. Just rota and balloon has done a great modification.
Good. That's okay. That's good.
I won't see
Yeah,
it.
you'll see it now. Good. Did already. See?
About the left main, there's, I think the balloon was too small for that, so are you planning using a bigger cutting balloon or?
Yeah, we can do. What size cutting balloon you use on the right side? We have that.
we have it.
3.5. Yeah, we can do 3.5
Give me
for the
some
distal
dye. I
left
don't know
main.
where the circ is.
Want to seal the right?
Yes.
I think there is some recoil in the left main.
Yeah.
Show some dye so I see where it is. Yes.
This is the fielder wire trying to wire the circumflex. I think there will be a significant lesion. My prediction will find a significant lesion in the circ, ostium. I don't know what our panel and John you feel. Anyway, okay.
But I think I'd go with the assumption that's going to be the case and plan on what my strategy would be.
I mean, doesn't look like much. Oh no, there is a calcium, but not at the ostium. There is a circ calcium angiographic about 5-10 millimeter from the ostium, but there the lesion is about 30-40% only. So whether osteal, two things. Is there osteal lesion of the circ? Second, is it calcified? Those are the two things we are going to see with this.
I think this will be the deal breaker. I think this would be an area I would more likely shockwave if there's lots of calcium.
Okay.
Any comments from the panel?
And like your idea of the IFR, that's what I do usually. I mean, if the IFR is negative, then we are done unless there's, plaque shift or something else.
You know,
Others?
if the rest of this case is any guide, there's a lot more calcium than the angiogram is showing. So the LAD didn't look that calcified where it was getting stuck, but clearly,
Okay, start to work.
Okay, show the IVUS on the main.
Yeah, this is a
You
proximal
see about
circ.
50%
Yeah,
of it on angio.
like a 270 calcium in the proximal circ. Yeah, I'll stop it. Yeah, start of the pull work is fine. This is the OM. Yeah. This is osteo circ, eccentric calcium. Yeah, prox circ also like a 270 calcium here.
Oh, tight. Now to use
Yeah, here's
IVL.
almost 360.
You think IVL make a turn?
Yeah, IVL will make a turn.
Okay, so give me the diameter there.
3O.
1, 2, 3, 3O.
Yeah, lumen is like 2.23. The
Okay.
vessel size is like 3.3.
So basically, osteal IVUS, osteal circumflex has a disease. Then there is a plaque after that in the main circ with the very calcified, right? That's
Yes,
the
yeah, exactly, Dr. Sharma. It's a proximal circ, a lot of calcium.
the full circular calcium there.
Yes,
Yeah?
yes.
Like 322
Yeah.
degree arc.
The prediction on more calcium than we could see angiographically is correct.
Yeah. Good. Go. Yeah, so let me take you back there. So
Wait. Okay. So we are okay with 3O IVL?
Yeah, I think
Not
so.
3.5.
The next
Go
question
back to
becomes,
the
can you
ostium.
deliver the IVL primarily?
Yeah, that's what my thing was. Okay, would it go?
You can't,
Because
by general rule of thumb, if you
1,
can't get the
2,
IVUS
3.
across it, you don't get the IVL.
but this case I was went in this one. No. In this one I was went in.
Wiggle wire? Yeah.
Yeah, what the other
1, 2, 3.
suggestion is a wiggle wire.
No, but but remember we have IVUS already crossed this proximal circ. IVUS did not cross that mid LAD which we already taken care.
No, that's not the thing. Myself
But
and
you got all the way through the
Kiski were deciding, do we go 3O or 3.5?
3O.
At certain
3O.
places it looks...
3O. No, yeah, okay. 3O is good enough. But I wanted to bring the attention to this scout film. See that circ osteal is about what 180 degree calcium. How much is the osteal circ
Yeah,
calcium?
eccentric calcium, you see like a 9 up to the 1.
Only 90. But see after that's where you see the circular arc.
Yes.
Show it that your circular. See that here.
Yeah.
The complete 360. See that's what I predicted based on the angiogram. So exactly on the angio, what with the confirmed on the IVUS that ostium. Only thing I could not say clearly that what was the osteal circ. So osteal circ is the tight. There is a circumflex with a severe calcium just after that, and now we are ready for IVL, which is okay. Because I say that diagonals and the circumflex are the notorious for perforation with the rotablation. And if you can avoid it, use particularly with the IVL, is the best thing possible. So this is particularly diagonal. So highest perforation of the diagonal, if I say highest perforation of the rotablation at Mount Sinai Cath Lab, knowing there's 75 rota per month. In the past, used to be all in the diagonal and OM. Rarely in the main vessel RC or LAD. And therefore, in this particular case, if we can avoid doing the rota of the circumflex and come out with the IVL, will be great. I would say great teaching point.
So if you can't get the IVL to make this bend, it's a pretty tight bend in a calcified lesion, calcified vessel.
Then I would use a
Are you
2.5
gonna
balloon.
go to-
No, I would go 2.5 12 balloon. First non-compliant and then go with the IVL. So pre-dilatation with the non-compliant balloon. I don't think I will go with the cutting balloon in that situation. We'll just go with the go.
Are you comfortable with your circumflex wire position? It's not very far down. You make it a lot more back up if it's a little farther down.
Yeah, we are doing it now. Yes, absolutely. Yeah. Good. That's fine.
And looking forward here, guys, if you IVL the circumflex, going to do the same to the distal left main osteal LAD?
Yeah.
I'm just wondering.
Good.
With
That's
such,
good.
No, I want up till here.
Yeah. Okay. Go. 4.
With that 270 degrees angulation of nearly concentric calcium in the osteocircumflex, and it's not really a subtotal at the ostium, wouldn't that be intuitively
No, go up.
sort
You
of
go 6.
effective if you were to put a stent from the
Okay,
left
not a
main to
negative.
the LED?
Go again.
It might decrease the
Go up
incidence
again.
of severe pinching of the osteocirc. I'm just asking, wondering.
So I couldn't understand the real question. Basically
What?
was
Pinching of the osteocirc at
6
one time.
and 8.
Good.
Yeah.
Okay.
Yeah.
So the 270 calcification is in the proximal circumflex and not at the ostium. Is that
Right.
correct?
That is correct. Yes.
Okay.
Okay.
Yes, go up.
Okay, thank you.
Yeah.
Well, good enough. It looks like you had no trouble getting that IVL catheter down
Yeah.
there.
Yes.
Yeah,
I didn't
then
realize
6.
that you got the
Yeah.
IVUS all the way through there, so that's
Yes.
still
Go up.
congruent with our usual observation.
Negative.
Okay, not done it. Okay, go up again. Yeah, negative.
And we can go now 6, but they don't go beyond 6. There are new technology which are
Stop.
coming now,
Stop.
particularly the bolt. They go to 6 now, and 6 and 8, but don't go beyond that 6, and then before coming down 8, because this is like 3. What is the vessel size? 3.25 or 3.5?
3.5.
Yeah,
That's why I
circuit,
said
yeah,
could have
3.5.
gone 3.5.
That's okay.
OM is 3.0.
Good. 8 and negative.
You want? We have
Like these
3.5
fellows holding
cutter.
up well with
No, we
you.
don't.
Yes. Go up again.
Blood pressure looks good.
Yes.
So after IVL, are you going with the NC balloon there to the circ?
Yeah, that's a
No,
very
I
good
think
point,
that's
yeah.
important, which we don't do with IVL. We can IVUS and show it has done a
6 and 8.
good
8 and
modification.
out. Good.
You don't need
Out.
to go back and do a high pressure balloon. The question is, since we were discussing what should be the size of the balloon, if it's 3.5 and have a 3.0
Not
balloon,
even picture.
do we
No
have to
picture.
get
No.
a, okay,
No
let's go IVUS then.
Yeah,
No picture.
No picture.
That do we need to go back with a 3.5 cutting balloon, which we have here.
Yeah.
We used it for the RCA, just
Then
because
use
we have it.
Yeah. So let's do the cutting balloon, then we do the IVUS.
Yep.
Let's get a
Okay,
3.5.
no, Kiski, you want to do that or you want to do now to see if IVL has done anything?
So IVL expanded well.
You did.
Yeah, then we can do
Any thoughts
IVUS.
about OP and NC for this type of lesion?
No, if you're not using the, yeah. So I mean, I would say
Give me
that,
IVUS quickly.
that will be role if we are not using other, we already have done
Okay.
that
I
if,
think we've got nice
yeah.
stability of the patient here. It'd be really interesting to see with IVUS, what the shockwave has done here.
Yeah, we are doing it now. So before even doing a cutting balloon, F1, whether cutting balloon is needed, we had 3.5 used for the RCA. Whether should we use it? But this is what IVL has done. We'll see it now. You can pull back the wire. Let me see.
Okay, pull back
Yeah.
the circ wire. Yeah.
Did-
Okay, pull back closer.
No,
Okay.
one second.
Ay, ay. That's what
They
I was
have to be
thinking.
this way. Okay, leave it. Go. Done. Remember, this has to.
It's a nice representation.
Okay.
You're doing a lot of work.
Okay,
Very
check
low
the image.
Yep.
Okay, start fullback. It's
Main
on the
screen,
OM.
IVUS.
Yep.
Please.
Can we put the
Proximal start,
hemodynamics
yeah,
by
much bigger
the?
lumen and left main.
Okay.
Yeah, it's a short pullback. I will stop it. So this is a start on OM, and this is a proximal circ. This was the 360 part. Yeah, of course it's an IVUS. No clear, but yeah, definitely the area is like much bigger. It was like 3.8. Now it's 6.4. Here is also like a 4 point something.
Get a 3.5
Push.
cutting balloon.
Yeah, so that's actually answers the question about doing an NC post IVL. You've got to already have excellent expansion of your lumen.
Yeah, and my thought is that I usually use DCP for this kind of side branch and then stent from the LED to left main. It's a very simple, procedure.
It's quite a focal lesion, so DCB can work
Works
quite
very well.
nicely.
Very
Exactly,
nicely. Yeah.
in an area that you don't want to put too much metal.
But are we sure it works in calcium? With
Yeah.
such heavy calcium, I'm not sure about the long-term result here with the DCB.
I don't know what the long-term results of an 87-year-old male with an EF of 27.
Lecture earlier about DCB and calcium, unfortunately, I didn't attend.
Yeah, in the October trial published in New England, Circ ostium was the most prominent place for, restenosis.
Let's go. We're going to go up.
If there is a stent layer, it's much more difficult to be treated in comparison
Hold it.
to this.
I'm going up.
Yeah, I luckily went to that lecture earlier, and some of the
Okay.
results from that
Down.
were amazing, right? Came back several months later and a year later, it looked fantastic, even
Good.
despite the
Good.
calcium.
In the IVS passed, so it wasn't that much of calcium. I mean, this is moderate calcium, not severe. We've seen lesions where you can't pass anything, and just I think this one.
That's why I
not
wanted the
well.
3-5.
I just got to ask
IVL.
the U.S. investigators and operators, because of the cost of DCB, I mean, is your lab allowing you to do it in non-ISR related lesions?
Yes.
Silver.
Careful.
Yes,
Now
okay.
this is 3-5.
No, but the point is you can use it, my friend, but you will not be paid. You can use anything you want, but with
Down.
zero payment. Right now, the payment of the DCB is only for Medicare outpatient, not even inpatient. 5,500 is down the drain.
Do some calcium modification.
So which raises the question,
Yeah.
now that you've dilated the osteocircumflex,
Yeah.
what's the ultimate plan for the bifurcation left main LED circumflex?
Yeah, so our goal was always to the mini crush. 2 DS, yeah. So tell us, we have 5 minutes only
Okay,
left.
good. Take a picture. Now
Okay.
we need an angiogram to see and decide. So the length of the LED will be 38, 3038, right?
Yep.
And the circ, what do you get?
Circle will be
30?
23.
30?
3 or 23, yeah. Go.
I would put a 28. Yeah, 23 is good.
Okay. So our original plan was the same and we kept it the same way. But you're right. Some people will use the drug-coated balloon, but I can tell you,
You mean 3 or 23?
I still yet to have a trial when there is a large size vessel, side branch, and you compare the drug-coated balloon with another DES. As to my knowledge, there is zero. I know we do a lot of anecdotal thing, but there is
What
no.
is this?
Here. So
3 or 23?
question is, so what would you do now? If it is a small vessel, less than 2.5, I will be more, I would say, proponent of the DCB. Yeah, this is for the SIRC.
Tell them to put the app.
Yeah. So that one, so because of that, and you still need to be, and remember all the other trials now coming up, some excitement about the drug coated, but large vessel may not be the right thing to do. Although we just have a nice review, we published in the JAMA Cardiology, the use of drug coated balloon worldwide is 2 different ways. It is anywhere from 2% to 32%. Actually, England and so very high DCB use. In America was 2% largely because it was not available. But the question is that what is the right approach? What is the right percentage? Should it be the even large vessels also? To me, what I would say, that one of the biggest use of the drug-coated balloon will be in our interventional armamentarium is where you want to really truncate your depth use. So particularly bleeding patient. I think that's where it will really be fly.
So for those on the panel from Europe, and you're doing a distal bifurcation stent, and you're using DCB for the side branch, when are you deciding to use a 2-stent strategy? Or
No, that's we are doing. No, the question I said that there is no trial which has shown that large vessel, your DCB was in the side branch was better compared to a 2-stent approach.
Actually,
Okay, ready?
that's true. And
Ready?
Take a picture.
We are starting a trial in Europe.
Yeah.
Europe Bifurcation Club is starting a trial with the Metronics
Good.
Prevail balloon.
Hold on. Distally we have
two-stent
covered
strategy
enough.
with,
I am going to go in the left
One
main.
minute, yeah. Go, push
Very
it.
interesting to see the
Which is
results.
which is
Personally,
what?
I use
This is the
two
diagonal.
stents when there
I mean,
is
sorry.
a compromise.
LED I'm
in the
going in
side
a little
branch,
bit. Okay.
long
Okay.
distance.
It's good, no?
Okay.
Here you can see angiographically that there's a little bit compromise in the circ ostium, so this is a borderline case for me for the DCB in the circ.
Yeah, I was wondering about that. There's definitely some
Down.
compromise. It looks like at least calcium in the circumflex.
Okay, go up again. Okay, good. Down.
So this we went to it was a 3O or
323.
Yeah.
3O23. We went to 16 atmosphere.
Show me some dye. Distal
No,
edge.
no need to see dye.
Distal edge. No need? Before
Okay.
I take out the wire.
Yeah, take the wire out. Show the dye now. She wants to see the dye. Good. Yeah.
Okay, go up with the left main.
So now we are going to go with the left main.
Kiski left main 3540.
Yeah, at least follow.
Okay, get us a 408.
So what I know, we are reaching the time. John, whenever the
Down.
time comes, we can come off because we are going to show you the last picture. And of course, we'll optimize now with the imaging point of view. First, we'll do a pot with a 4 and then do a kissing balloon.
I mean, you're actually doing pretty well. You're staying on
Oh.
time. You got about 17 minutes.
Oh, 17 more minutes. Oh, good.
Oh, that's a lot. We can do another bifurcation.
Other triple vessel disease, 87-year-old somewhere?
And how did you
Yeah,
like it?
please.
How did you like it? 1
Get
year
us-
later, similar patient.
No.
What identical patient was when I was making the slide? I said, whoa.
I
No,
thought you were having a lapse there and you were off like a year.
Yeah,
I said we can do another case quickly.
good.
Okay, now we're going pot 408.
Yeah.
So we have the app steps playing in the side.
Yep.
That's the bifurcate 3D. We have all the other apps. Final slide if you have to show.
So, Dr. Keeney and Samin, somebody's thinking this. I want to know why you're using a mini crush rather than a DK crush.
Yeah, so I mean, both are
I know
good
it's coming.
except the steps. Just the
Go.
extra steps
Go.
because you're right.
Go.
Any one of them. Crush is the one. Although it's, the European, I know a lot of European, our guys and experts are there. That they will do a EBC main, the step provisional stenting, but that go to do the kissing balloon, and if necessary, then only you put a stent of the side branch. So that's a strategy. You're right. Every time the question is asked for us that why not DK crush, I think still I'm skeptical that whether DK crush is does any more advantage than the mini crush. People say, well, maybe you would do a better crossing of the side branch once with a DK crush. Sometimes we can take care of that before taking the balloon out of the side branch, a little projection, then you can go to high pressure, like try to open the ostium, but the time when we do a more DK crush will be the radial, that use a 6 French device. So you want to take a picture now? Or you want to do the
What
iris?
you suggest is what I often do is take the side branch balloon and go to high pressure as I'm coming up.
Yeah, that's right.
and then,
Yeah,
Deploy the other part.
that's
And,
correct.
Just do a low pressure on the main balloon after the stent's been deployed.
That's right.
It's kind of a mini, it's called a mini jail stent balloon.
Yeah. And we have never had any trouble. So yeah, so nothing wrong in that because the guideline 2B is your DK crush for the 2-stent approach for the left main. But yes, other technique still it's not a class 1 because only one group from China has shown to the benefit, superiority of that against whether culotte or.
Now take a picture.
Okay. Taking a picture and ready for
One
iris.
benefit to this again is that recrossing is so much easier.
Yep.
So you can take your workhorse wiring
Yeah.
you started
Yep.
with and go right
Same.
back through.
3 or 12 high pressure. What is this?
2.515. Yeah, that's fine.
No, we're not going 15.
That
Take
looks
3 high
beautiful.
pressure.
I just have 2 quick comments.
3 or 12 high pressure.
The DK crush was
Let's
better
talk.
when they
Yeah.
had long lesions, more than 12 millimeters. And the lesion here is relatively short. The second issue, I think, to optimize the procedure, it's always in the technical details and the steps. And I think one of the steps that sometimes is overlooked, which I think is critical to minimizing the restenosis down the road, is when you do the kissing balloon inflation. It's critical to deflate the main vessel balloon first, and then deflate the side branch. Otherwise, you get sort of recrushing.
You want to
That
give a 2 or
increases
12 balloon?
the potential
It's not going.
for the restenosis.
So this one is a 3O balloon. We want to go with a high pressure, not crossing, which is not uncommon. So we
Okay,
can use a
Other thing is, wait. Do you want to anchor?
Anchor, yeah.
You have what balloon for the LED?
3O, right?
You have a 3O balloon for the
3.5.
LED?
Yep. So question is, we are not going, so we have the 3O balloon already, and we are going to anchor it with that.
15 you had
I
or
think
no?
one of the things that make DK crush
Okay.
maybe better than the mini crush is that you open the cell and it's much easier to cross to the side branch with the DK crush than the mini crush. And then sometimes you struggle with the mini crush to do the kissing balloon.
Is that a fresh balloon that's catching, or is that?
No, that we have to. So now we got a 2O. We are going to the 2O, a 12 fresh compliant balloon.
No, I'm doing anchor.
Oh, no, sorry. Right now we're applying the anchor now, actually. So we.
Usually, usually we have no issues when we are doing left main for the side branch balloon to go.
I'm never as good as you guys, but because I always have trouble. But I usually do
Okay,
a
go.
smaller balloon, pre-dilate, then go through.
Yes.
Yeah,
We
exactly.
definitely say that
On the LED.
in this situation, because it's heavily calcified, disperse are doing that. We have seen this can happen in in calcified lesions. But
Go. No.
good,
Oh.
good.
Yeah, see that now? The balloon anchor.
Nice example of
Yeah.
that.
Yes.
Anchoring.
Good. Okay. Down.
That's a beautiful demonstration. It makes the procedure much easier.
Yeah. Pull back a little. Other one also. Come.
Okay.
Good.
Go up. Now I was ready.
Yep.
Let's final IVUS. Yes. Go. Now.
16, 16.
Yeah.
You can go higher. 20.
No,
Do
that's
you
too much.
post-dilate?
Rupture.
Yeah.
Do you post-dilate the LED stent separately?
We did.
Yeah. That's what we did.
Okay.
With,
Yeah.
with the 3.5 3O.
Don't
Oh,
think you missed something here.
Now we can take one
You'll have
picture.
11 minutes, you can still do another case.
I know.
No, but we'll just show the IVUS now.
Yeah, yeah.
We can after this again.
Actually, that is what, same thing we said for the TCT. Next time maybe with the CRT, we'll tell them also. We do 2 cases. With the TCT also, they wanted 2 cases in that 45 minutes. So I think, okay, if you give 45 minutes, the 2 cases is okay.
Well, I'm pretty sure if you didn't have to break scrub, you could do them at the same time.
Well, alternatively, you could take on 3 vessels with 2 CTOs, right?
Okay, good. All right, let's do the
IVUS. So we're going from LED
Yep.
first, flush, and then we go to the circ.
Okay. All right, let's see it.
Flush.
Need to believe it. Go.
Where?
How high pressure did you use on your crush, on your kiss?
Individually we went 18 and then final about 12.
Yeah, so question is then a lot of people say now we do a report. I mean, we actually had the paper again in JAC intervention, the data for pot and pre-pot, every case we start doing non-left main, we said. Because there is no, it's a, many things we do because we feel like it looks good, but truly can it be substantiated by any studies, and so is a little
Okay,
questionable.
show me
Okay.
IVUS.
Okay.
Show the IVUS on the main screen, please.
Can
That's
we,
the money shot.
Okay.
Yes.
I start to work.
Yes.
Hmm.
Nice.
Yep. Circle shape. Expand it. Left main.
Are you sure there was a lesion there?
Yeah. Good. Let's go to circ now.
Okay, now we go to the circ.
How much contrast did you use until now?
We'll tell you.
We'll tell you at so far we are 90.
Yeah, as long as we see the stent is
Flush again.
we are not sure distal edge.
Good.
Proximal edge looks good. Good transition.
2.3.
I'll go to the circ.
How much is it? Distal left main?
1 second. So
MSA?
LAD is 5.6 and left main
5.6 only?
distal. Distal part of the LAD. Yeah. Left main is like 12.
Okay, good.
But I want LED at least 6.5.
I mean, proximal
He's-
LED looks great, like
Yeah,
7.
he's
but,
giving you the distal edge
yeah.
near the bridge.
Yeah, 5.6.
Like, leave it, leave it.
What's next?
No, we are trying to
Circ
IVUS the circ.
Okay.
Take the wire of the LED out.
No, that's not the thing. That's just that.
Or
can show
pull
the
the
angel.
guide
Feel it.
more aligned.
No, no, nothing of that.
Yeah. Yeah.
That's not,
Now
that's
go.
not
No,
enough.
1 second.
No,
One-
we need more wire purchase,
Okay.
but we don't have the enough wire purchase. Tip is. Hmm. Maybe I can put the LED wire in the circ.
Good.
And let me see if that will do it.
The wire tips definitely get beaten up
Same
in
wire
these
multiple
complex
times.
cases. Good.
That's a
So
lot
body
of
wire.
products.
Yeah.
Good.
Great.
Try this at
And-
home.
Yeah.
Yeah, don't try this at home, exactly.
Okay.
Okay.
IVUS again.
Okay, can I start?
Distal edge.
It's
Yeah.
inside a stent.
A
Yeah,
little further.
that's all you can.
That's
Okay,
okay.
Okay, start
be
to work.
happy.
Yeah,
Be happy.
yeah, stent well expanded. Proximal circ, left main. Yeah, I'll stop it.
Good. Everything out. Give 40 of Lasix.
Okay, some nitro. Little bit nitro, verapamil.
Let's give a little bit
Also circ like 5.
Okay. But we have a nice.
Good.
Yeah,
Okay, let's
proximal
take a
circ
picture.
is 6, 7.
Show the lastly the picture. The money shot. That's it.
And
Start weaning the impella. Look at that. Beautiful.
All right.
So we see a beautiful lumen. The diagonals hung in there okay.
All good.
Side branches all look good.
Yes.
And
I
tell you
call-
what,
Hmm.
you can't ask for better than that, and you did it with what, 100 cc's?
Yep.
Yes.
That's it.
Of that, we have to count 10 or 12 cc for the groin pictures.
Yeah. Which is all right. But I'm glad that we had a good discussion. Various options, various planning strategy, and decision for IVL. I would say for the circumflex with that circular calcium was right. And a good expansion of the circ stent. Actually, the lumen they got nicely about 5.9 even, bigger than LED, mid to distal LED. LED left main are very well expanded. And if no question from our panel, we really thank from the Mount Sinai Cath Lab.
So can you comment before you go on your plans? Are you going to wean the impella and remove in the cath
Now,
lab?
already
Yes.
we're doing it now.
Yeah, weaning
Yep.
is going
Yeah.
on. Yes.
So right now, I can tell you, we have been in last 7-8 years about the 350 cases of impella, the various trials, impella or other new MCS device. All 5 MCS devices which have been used in last 2 years, we have used in Mount Sinai Cath Lab. And maybe in 352 patients, we left the impella. And one of them actually we changed impella to balloon pump, but otherwise we have good intervention. Just take it out. Every case we do. Yeah.
Well, guys, masterful job as always. Congratulations. We definitely appreciate the complexity and the learning. Excellent. Well done.
Thank you.
Thank you.